Your Health and Family Matters prostate cancer awareness. 1 of 6 black men will develop prostate cancer in his lifetime. Additionally, they are 1.7 times more likely to be diagnosed and 2.1 times more likely to die from prostate cancer than white men. For a discussion on the importance of knowing your family history and prostate cancer screening, get your hands together, cold brother, too, Dr. Yaw Nyane. Did I get it right? Nyane?
Yeah. Good morning, everybody. My name is Yaw Nyane. I'm a urologist practicing in Seattle at the Fred Hutch Cancer Center.
I'm sorry, we're going to do that again. Excuse me. Excuse me. Get close to the mic.
Yep.
Speak up so I can hear you.
Can everybody hear me?
Louder, sir.
Can everybody hear me? All right. Good morning, everybody. So as I was saying, I'm a urologist in Seattle, originally from Oklahoma by way of Georgia. And I'm really excited to be here talking to this crowd today about prostate cancer in black men. And I think you already heard some of the statistics. But what I want to do is paint a picture for everybody to understand that this particular issue is a crisis. That's how I see it, right? Black men are twice as likely to die from this disease, and it's a disease when caught early can be cured 99% of the time for most people. So I'm going to go through some slides just as background information, but I want this to be a conversation, and I would love to have that microphone so I don't have to stand behind this podium. Thank you. Okay, perfect. So, hard to follow a comedian. I don't think I've ever done that given a medical talk before, so I appreciate that very warm introduction. I hate to put a picture up of a prostate while y'all are eating breakfast, but what I realize is a lot of people don't know what the prostate is, right? So we talk about prostate cancer, probably start by what is a prostate. And this picture here shows a bladder, it shows a prostate, which in a young man, like an 18-year-old man, I say a prostate's about the size of a walnut. So this is not a particularly large organ. Obviously, as men get older, it gets bigger, which is why you can see here your urethra, the tube that drains urine out of your bladder, runs right through the prostate. And when I see men for prostate issues, I think sometimes there's a confusion of what cancer is versus enlargement, okay? So you can see you can have a prostate get big, and that can block the flow of urine, but you can also have a tumor grow in your prostate, and that's just abnormal tissue that can't be controlled by your body, okay? Now, prostate cancer is the most common cancer in men in the United States. About 270,000 men are going to be diagnosed with prostate cancer this year, and about 40,000 men, 42,000 men will die from prostate cancer this year, okay? And so if you think about prostate cancer being that common, the first question you might ask yourself is, well, what are some risk factors, right? So as you get older, you're at a higher risk. If you have a family history, you have a much higher risk, okay? And so about 20% of prostate cancers run in families. And about 10% of those cancers, we actually can find a genetic cause for, okay? And so I have a little pie chart here, this little picture that shows that all these different genes that are associated with prostate cancer that is either really aggressive or has spread stage 4. And the reason I put this up is not to test anybody on cancer genetics, but it's to point out that knowing your family history matters, right? So 2 of the genes that we see on there are BRCA2, also known as BRCA2, and BRCA1, which is BRCA1. And those are named that because they were originally discovered as genes that increase your risk of developing breast cancer. That's how we came up with BRCA. And what we have learned in work that was really led by my colleagues at the Fred Hutch Cancer Center is that BRCA mutations, for instance, increase your risk of prostate cancer, right? So now when I see a man and I ask him about his family history, I don't just say, hey, does someone in your family have prostate cancer? I ask about breast cancer. I ask about ovarian cancer. I ask about colon cancer. All these things can run in families, right? And so one of the important messages that I wanted to convey today is that it's not enough to just know a little bit about your family history when it comes to cancer. You need to know all of it, right? Because if it runs in your family, it can increase your risk in your lifetime of detecting, of having a disease like prostate cancer. And you know, I think we have to normalize these conversations about what's going on with people's health in your family, because that affects your risk, affects the risk of your children and their children, and so on. Now, I'm going to transition from that 20% number to my next slide and highlight some statistics. Oh, they're not up. That's all right. We'll just keep my slides up. So, prostate cancer in black men. The average man in the United States has a 1 in 8 risk of having prostate cancer. Okay, that's all men in the U.S. For black men, it's 1 in 6. Okay. 42,000 black men will be diagnosed with prostate cancer this year, and it is the second leading cause of death among black men due to cancer. Okay, and a lot of discussion about this comes up to me when I meet with patients, right? Doctor, you know, Dr. Yaw, as they call me. Nobody knows how to say my last name, so everybody calls me Dr. Yaw. Dr. Yaw, why do I have prostate cancer? You know, is it something genetic? And I'll tell you that is an easy way to try and explain away what we see happening in the black community with regards to prostate cancer. Okay, black men are twice as likely to die from prostate cancer. All right, I'm going to say that one more time. Black men are 2 times more likely to die from prostate cancer, a disease that I told you we have a blood test that can help you detect it early, and we have treatments that are 99% effective in most prostate cancers when detected early, okay, and treated. So this is not a biology issue, right? Cancer is a biologic phenomenon. I always say biology is in the mix, but this is a structural and social issue, right? And one of the things that I always talk about are the structural determinants of equity. We always talk about social determinants of health, you know, as public health doctors, and we focus on the things that we know directly impact an individual's health. But that lives in the greater context of our communities and the world that we live in, and that is impacted by things like structural racism, environmental racism, systemic racism, and all the other isms that impact, you know, communities like the black community and other BIPOC communities. And so I wanted to make that point today, because this is something that we can prevent, and it's something that we can defeat. And I believe that wholeheartedly. My entire research program in Seattle is around trying to understand how we can create equity when it comes to prostate cancer outcomes. So, achieving the impossible. If you guys look at me, you can tell I'm not an ultra elite marathoner, okay? I run a couple of miles once a week just to feel like I get my steps in. This guy, Eliud Kipchoge, ran 26.2 miles in 2 hours. All right, I've done the math. I think each mile was like 4 minutes and some change, which is unbelievable. And he did this in Austria. It's not a sanctioned race, so it's not an official marathon time, although he gets closer to that mark in official races all the time. And I love putting that picture up, right? Because it's him, his hands are up, he's achieving what people thought was impossible. But if you look, he's got, what, 6 guys behind him, and those were his pacers, right? These are guys that ran portions of the race with him to make sure that he could keep that speed and pace throughout that very long journey. And even more important is the crowd behind him, because this is not, again, this is not an official race. My man woke up and decided he was going to run 26 miles in 2 hours, and a bunch of people showed up to cheer him on. So to me, what this picture highlights is that if we want to do something impossible, quote, impossible, we got to do it together. And there's something to be said about having community and coming together to achieve a task like this one. And for me, what that's looked like is this. When I started my position in Seattle in 2020, of course, the pandemic has started, and I really wanted to understand where the needs were for addressing this particular issue, okay? Like I said, we have a lot of testing. A lot of people are worried about prostate cancer screening. I hear this from men all the time. I don't want to get screened, doc. I don't want the finger exam. As a urologist, I say, we're not that thrilled to do the finger exam either, but we care about your health, all right? So that's number one. Number two, PSA, the screening is really a blood test, all right? So get the blood test. We've gotten plenty of needle sticks in the last few years for our vaccine. It's the same thing. So it's a PSA test. That's the screening. And I mentioned the treatments. I'm not going to get into them, but we have a lot of them that work really well. So I knew that one of the things that was missing, though, is black men from a lot of our research, right? Black men represent 3% of prostate cancer clinical trials that have been published to date, 3%. And I just told you, you're 80%, almost twice as likely to be diagnosed and twice as likely to die from prostate cancer. So where are we in the research? So I reached out to a community leader in Seattle, and I said, I want you to join me and my research team and tell us how we can make an impact in Seattle. And and through his network, I was able to, that's Ben Young on the far left, and through his connections and people at the Cancer Center, I met Victor Tolbert, who's a former football player, who's a personal trainer, trained some of the Seahawks. Sadly, he's left Seattle, but he's still part of our team. And then Dante Moorhead was a community health educator who joined our team. And I'm proud to say Dante is now matriculated into a PhD program at the University of Washington to expand his work. So this little team came together and started to think about what kind of things we could do to impact research, right? So what we do is not about advocacy, because there's a lot of that exists. I see American Cancer Society back there. We've got organizations like Zero Cancer. We've got the Prostate Health Education Network, which is an advocacy group for black men. But what's missing, in my opinion, is a community-based organization that can help us drive research initiatives. And so that's what we are tasked with doing. Our organization is called Backpack. And to date, I'm proud to say that we've received 5 grants, okay? 5 grants to do research on prostate cancer disparity. So at this point, I like to say we're like Google in the garage. We're not big time yet, but I think together with folks like you in the audience today, that someday we will have clinical trials that enroll 100% black men, that we will find solutions to create equity, and we will look at this time and say, oh man, isn't it crazy that black men used to die from this disease? Because there's no reason for it, all right? So with that, I want to say thank you again to the organizers. It is absolutely a pleasure to be in LA. And I'm happy to answer questions from everybody. Thank you.
Good morning. I'm Dr. Jim Black. I'm a retired dentist, and I've had 2 brothers who have passed because of prostate cancer. I understand you did not want to speak about the modalities in terms of treating patients, but would you just elaborate on 1 or 2 that might be of helpful for us men to understand treatment of prostate cancer?
Absolutely.
Thank you.
So, prostate cancer, obviously, it's a disease that can have many forms, right? So the first place that I usually start with the diagnosis is it in the prostate alone, or has it spread? Okay. If it's spread, then it's something that we can control, but not necessarily cure. And we got a lot of treatments that give men, on average, 5+ years of survival and good quality of life. But that is one set of treatments, okay? Now, the area that I specialize in and that I want to focus on is that localized cancer, or the one that's within the prostate, because that's the one that we can cure, right? And that's the one that we tend to detect, because somebody gets a PSA test, it's a little bit high, they go to a urologist, they get a biopsy, and we find cancer in the prostate. Now, once that happens, you actually have 3 options, okay? We have some cancers that will never be fatal or will never kill an individual as far as we can tell. Those are those very low-risk cancers, and we watch you closely. You meet someone like me twice a year. We do biopsies every 1 to 3 years, and we monitor it really closely. And if it looks like it's going to be a bad cancer, then we can offer you treatment. The other 2 treatments are surgery, which is what I do. It's actually a robotic procedure. Most men spend 1 night in the hospital, go home the next day. And the other is radiation, which can be given in a bunch of different ways. But one of the things that I will tell you is that surgery and radiation are both equally effective in treating prostate cancer. They have different side effects. And so one of the things that I spend a lot of my time in a clinic visit explaining are what those side effects are and trying to match a treatment to someone's preferences. All right. So, but that's a kind of a high-level overview of the different treatment options that exist.
Your question, Dee?
I'm Karen Jackson with Sisters Network, and I'd like to compliment you for being here today and speaking to this audience.
Thank you.
Thank you.
My question is to say to you, as a black man, talking about breast cancer and being a physician, you need to speak to more female groups and organizations, because as a female organization, we have husbands, brothers, fathers, co-workers, and sons that need to have this information. So the more we know, the better our families and our community is going to impact prostate cancer. It does work that way. Thank you.
Yes, ma'am. I couldn't agree more. So one of the things that I didn't show in that backpack slide is that we have partnered with 29 organizations in Seattle, and the ones that respond, all the emails we send are our sisters and our women advocates. They always seem to be the ones that spread the word about the work we're doing. As we expand nationally, we look forward to partnering with more organizations. As I said, it takes a community, and I think that message is very true.
That's right. And they got first cousins too. Okay, I'm sorry. Thank you, sir. You're doing a really good job. You're doing a good job. What's your name, ma'am?
Angel.
Angel has a question.
Yes.
Yes, ma'am.
Good morning, and appreciate you, and I'm giving you your flowers for actually completing your scholastics and actually becoming a doctor for us. I appreciate that myself. I just had a question about the clinical trials because I'm concerned about the cultural mistrust with our history in the West of how we've been misused and mistreated and even having our organs harvested. With these clinical trials, will they be completed by black entities or people of color, melanated entities, so that we can ensure our own safety as well as trust?
Yeah, that's a great question. That's part of why I thought backpack was needed. And as you can see, you know, there was an intentional focus on having black men and members of their community at the table, setting the agenda, designing our studies, informing people who run larger clinical trials. You know, the truth is it's a really complicated scenario, right? Because participating in clinical trials has the risk of exploitation, as you mentioned. It also is expensive, so there's a lot of social and structural barriers that don't allow people to participate. And then there is that mistrust, distrust. But what ends up happening is when a physician who runs a clinical trial sees a patient, they use that sometimes to not offer the study. So if you ask black men who have prostate cancer, were you asked about a clinical trial, they're more likely to say no. And if you ask them, would you have participated, a lot of them would say yes. So I think we got to address this from all the angles to protect participants who are potentially vulnerable. But I also think we need to make sure that we offer clinical trials, because that's what's setting the agenda. You know, a clinical trial gets done and gets published, that's standard of care. And you're excluding entire populations from those studies, and we don't really know what the impact is in those communities. So it's important that we are more representative.
Thank you, doctor. What's your name? Antoinette has a question.
Yes, ma'am.
Okay, so in all of your research and going forward, how are you going to address the fact that we cannot get our brothers to go to the doctor?
I went Tuesday.
And also, can you speak to whether or not the presence of that gene is necessary or is always considered part of the diagnosis? Because what if it doesn't run in your family?
Yeah.
So how do you know what signs to look for if it's not present in your generational?
Yeah, so great question. I'm going to tackle the first one. I simply say I don't know, but we need to raise awareness, right? And every time I watch a game on a Sunday, or right, I'm from Oklahoma, so like the Sooners are playing on Saturday. I'm always have the TV on. I think what a time to and a captive audience to share this message. So I think we need to raise awareness about the importance of health. There are other barriers though, right? Young black men, if you're under 65, you might not be insured even if you're working. So I think we have to think about this not only as an awareness issue, but a social issue for a lot of parts of the country where access to insurance and doctors are not available. We need to train more black doctors because that is really important.
Maybe some type of incentives, because black men ain't going to the hospital unless a limb fall off. So maybe at the sports games you give away some free tickets to the Lakers or something. I don't know, but there needs to be a way to encourage men to go to the doctor.
We're going to bring you to our next backpack meeting and you can share some of these ideas.
Yes, sir. What's the second part of her question?
So with regards to the genes, I think this is where that representation matters, right? That chart I showed you was exclusively in people of European descent. And so there's a lot that we there's a lot that we don't know about how genes may affect black men. What I will say is that no, you do not have to have one of these genes to have a cancer. In fact, as I mentioned, only 90% or only 10% of these cancers will have a gene that we know about. About 20 to 30% of cancers run in families, which means there might be some genetic components that we're not aware of. There's a lot of fancy science terms for that, but needless to say, this is one of those arenas where doing the studies, having the representation will matter, because for that 10 to 20% that we don't know about, there may be some gene that runs in a family that we need to detect so that people can screen and get treated and all those other things that come downstream.
Thank you.
This young man put on a suit just so he could ask this question. And apparently y'all shop at the same place. Come down, sir. What's your name?
Daniel Covey. I'm a behavioral neurologist at UCLA. Great talk. Two questions. One question, is prostate cancer kind of like colon cancer, where black people get it a little bit earlier and are, because of structural determinants of health, caught later, so there's less that we can do for them?
100%. So average risk for developing prostate cancer in all men in the U.S., 55, which is why we start recommending screening around 55. In black men, it's about 40 or 45. So we've done some research in the last couple of years that's been published advocating that we not only make a recommendation for screening for black men, but that we do it earlier.
And the second question is, there's something called the Preventive Services Task Force, which usually recommends when to do screening, but a lot of times it depends on how good the data is for things like PSA. So do we know if that's going to get better in terms of making it widely like a standard for everyone to get? Sometimes I get it for patients, and sometimes I'm like, I don't know.
Yeah, so we're getting into the weeds a little bit, but 2 trials were done, one in Europe, one in the U.S., and the one in the U.S. was supposed to compare PSA testing to no testing, right? Well, the no testing group, about 80 to 90% of them got a PSA. The trial came back as negative, and so the recommendations have been really murky, to say the least, about whether we should offer testing. I think when you analyze that data more thoughtfully, there is a 20% decrease in dying from prostate cancer if you get a PSA test. The risk is that we may overtreat and overdiagnose some men in the process of doing that. I tell you what, if you're a black man and you're of good health, in fact, if you're any man and you're in good health, you should get a PSA test.
Thanks.
Well, that was wonderful, bro. I have one last question, though. Do you think they'll ever have the self-test for prostate where you could just You can just
All
go
right,
ahead and do it on your.
Good night, everybody.
Ladies and gentlemen, give it up to Dr. Nyane.
Thank you.